Good morning, everybody. It's truly a pleasure and a privilege to introduce an old colleague and friend, Dr. David Gozal. Dr. Gozal is currently the Dean of the John C. Edwards School of Medicine and Vice President for Health Affairs at Marshall University. This follows a number of leadership positions at Tulane University, the University of Louisville, the University of Chicago, uh, and of course Marshall now, and the University of Missouri. Sorry, he in his distinguished career as a pediatrician, pulmonologist, and a sleep physician, he's had over 900 publications with an H index of 145. He's been continuously funded by the NIH since 1992, and he's currently editor of several leading specialty journals, including Sleep, the European Respiratory Journal, and Pediatric Pulmonology. He has received multiple honors, including the Amberson Lecture from the American Thoracic Society and two honorary doctoral honorary degrees from the University of Lleida and the University of Barcelona in Spain. As I said, he's a worldwide leader in research in pediatric sleep medicine, and we're quite fortunate to have him today as the permotor lecturer. In addition to all his numerous academic accomplishments, his career as a physician scientist, Dr. Gozal is truly a Renaissance man. He speaks multiple languages, and he's just always fun, to talk to him. So I'm sure we're all in for a treat. Please join me in welcoming Dr. David Gozal.
Good morning, everybody. For those of you who are here, thank you for coming. And for those of you who are online, thank you for joining. It is indeed a pleasure and an honor to be here. First of all, thank you, Dr. Celadon, for a very kind introduction. Thank you for inviting to the organization and Dr. Dermody for the invitation to come and deliver the Dr. Perlmutter lecture. I met Dr. Perlmutter many years ago, and he was still at WashU as a pediatric gastroenterologist. And we've communicated over the years. I most recently saw him at the Dean's meeting back in New Orleans, and it was fun to talk about the past and his fond memories of his time here at UPMC and at the Children's Hospital. So it's thank you, David, for making it possible for me to come now and deliver a lecture. So what I am trying and cover today, as far as objectives for this talk, are three. One, just give you a very brief overview of sleep apnea in children. It is a problem that is growing, and we like to see children growing, but this is something, not a problem that we would like to see growing as much. Talk to you a little bit about inflammation and obesity as the two drivers that maybe be responsible for the growth of the prevalence of this very complex and yet apparently not so simple, even though people think that it is simple disease. And talk a little bit about our understanding of the morbidity of sleep disorder breathing in children, and allude to some of the advances that have happened over the last several decades. Now, for those of you who are not familiar, I'm sure that you already know about sleep, but just in case, obstructive sleep apnea consists in the intermittent, partial, or complete occlusion of the upper airway during sleep. These are, of course, their consequences, immediate consequences are increased respiratory effort that comes from the increased upper airway resistance or from the occlusion. But then, of course, you're going to have an asphyxic stimulus with, at the same time, desaturations and the increase in carbon dioxide. And ultimately, in order to terminate these events, you need to have an arousal, whether it is a complete arousal with electroencephalographic evidence of cortical activity or whether it is an autonomic arousal. Really, we don't know how much it matters, but nonetheless, this is kind of the quadratic functional derangements that we see. Now, if you're an historian, and I know Dr. Celadon loves to look back into history, so just for him, In fact, an otolaryngologist is the first that actually described the disease. He didn't know what he was talking about, but he talked about children that snored and that by removing their tonsils, at that time they did scarification, was a very brutal, without anesthesia procedure, not something that we would do today, but he noticed that they were improved. And so really that is the first ever description of sleep apnea in children. In the more modern version, Professor Christian Guilleminault at Stanford, a wonderful colleague that unfortunately left us a few years ago, described it back in 1976 and described all the features that I've just reported to you. So what is the prevalence of sleep apnea in children? Well, snoring is extremely prevalent and probably is the most frequent symptom that accompanies sleep apnea. Now, so if you ask parents, any parent, we don't know that we snore, but somebody else needs to be a witness to our snoring. Usually in adults, it's the bed partner for as long as they can resist the noise, and then they move out of the room, but when the walls start trembling. But for children, it is important that parents will watch their children sleep. And most of the time, they will tell us that it's when they drive in a car, particularly in modern times. It's very interesting that today parents are less likely to monitor the sleep of their kids objectively at night, and then notice that when the child falls asleep in the car or in watching TV or something like that, quote unquote, please, it's not a good thing to watch TV and fall asleep, but nonetheless, I'm not going to go there. This is where, so if you take all of these reports by parents, up to 27% of kids will actually snore at some point in time. Now, in order to make a little bit of communication among epidemiologists and so on, we define habitual snoring as the presence of at least 3 nights a week, loud enough to be recognized by the parents. So this is what we call habitual snoring. And the prevalence of this around the world varies between 7 to 12% in the US. In 2 surveys that were conducted in the general population, one by us some time ago in Louisville, we found about 11.7%. So we are within that range. How do we define the spectrum of snoring, which is not normal? I want to emphasize, snoring is not a normal feature of sleep. We should not snore at any time. The presence of snoring during sleep indicates the presence of upper airway resistance. You wouldn't be able to generate those noises within the vocal cord system unless there would be increased resistance and increased turbulence of the air going through the airway. So primary snoring, we would define as the presence of that snoring, but without evidence of gas exchange abnormalities or without any arousals. I just told you about the quadratic dysfunction. So those 2 elements are not present. And we don't really know to what extent this is actually innocent or maybe has some mild morbidity that may be buried within some of the other features and may only manifest over time. The upper airway resistance is a time where we already see some degree of respiratory effort that leads to arousal, and therefore this fragmentation of sleep ultimately leads to some of the features in adults. It will lead particularly to somnolence. In children, somnolence may be actually manifest, as you well know, as hyperactivity and inattention. So be careful. As you know, if you have kids, young kids particularly, comes the time of bedtime, they become wired, they start running around, they become emotionally labile, they don't follow orders or commands or any requests, and then suddenly they crash, and then you can flip them around because their blissful delta sleep has kicked in, and so wonderful. But please notice that there are symptoms. And then you have the actual syndrome of obstructive sleep apnea, which is, according to stringent criteria based on sleep studies or polysomnographic evidence, we believe affects between 2 to 4% of all children. So it's a frequent disease. It's a frequent condition, even at that extreme of the spectrum. I just want you to watch. This is with permission of the dad. I was the caretaker. I just want you to watch. I don't want to put the noise. You recognize the noise of snoring, so you'll hear it just a little bit. But what you see is the actual effort that, whoops. The tremendous effort that goes just with snoring. This kid did not have sleep apnea, by the way. So it can be quite tremendous, and it can be scary to some of the parents who think that something is really, really wrong. And it is, it's not okay. So we do sleep studies. Polysomnography today is the standard of diagnosis of any child. So you may wonder what do we do and how do we. Well, this is what a sleep study with sleep apnea. This is a child, a 6-year-old that we picked up in one of our surveys in the community, never had been referred. It was a first grader. And you can see several things I'm going to point out with this cursor. This is snoring, and you can see this is a kid that snores throughout the night. The bars, the thick bars on the top are rapid eye movement sleep. And you will, for those of you, of course, all of you are very astute, you will notice that there's a clustering of many of the events that are here marked, including saturation near at the bottom. The desaturations and the events cluster around most of the REM sleep periods. So if you get a question in your boards, for those of you who are residents, which sleep state is the most vulnerable for respiration, you know already the answer, rapid eye movement sleep, okay? And sleep apnea is no exception. So when you see this, it's very obvious to make the diagnosis and realize that something is very bad. You have these intermittent hypoxic events, you have hypercapnia, you have arousals, and it's no wonder that anybody waking up after a night like this will not be in their best behavior. But you have much of this. This is, again, an excerpt from a 30-second tracing during REM, rapid eye movement. Saturation here is 95%, so there's no hypoxia. Airflow is normal. You can see snoring happening. And for those of you who pay attention to chest and abdominal, they're actually paradoxical breathing. So what you saw in that kid is here represented in this tracing, except that if you measured CO2, you would intubate. And PCO2 being about 61 millimeters of mercury, the pH was 724, not a normal condition, right? And so this can be easily missed if you do not proceed with the standards that are clearly implemented in your pediatric sleep laboratory. But I just want to point out, this is called obstructive hypoventilation. It is a very frequent of children. It is usually not seen in adults. So our children, you should know, the collapsibility of the airway is less than that of adults. It's paradoxical. They have small airways, and yet the collapsibility of the upper airway is less than that of adults. And we'll see why this is important. So this is a typical sleep apnea. You see the cessation of airflow accompanied by desaturation in the presence of ongoing respiratory effort. And then after termination, you can see the shift in the EEG frequencies that clearly indicate an electroencephalographic arousal. This is typical of an event, and this is what yet another sleep study shows, in this case, a very severe desaturations with reductions of REM because the kid cannot enter into REM because of the multiple arousals and awakenings elicited by all these events and desaturation. So again, another feature, and you can see the variety of phenotypes that you can see just on the basis of the sleep study. So what are the conditions that are associated with sleep apnea in children? Well, the first and most prevalent is adenotonsillar hypertrophy. I'm sure all of you know this. This is not a surprise. And the second one is obesity. But there's a long list, which I will not read for you. I'm sure you can do it by yourselves. But there's a very long list of conditions that are associated with a high frequency. And one in particular or two in particular that I would like to point out are Down syndrome, where 50 to 70% of all children with Down syndrome at some point in time will have sleep apnea. This is important. The other one, which may not be as evident, is cerebral palsy. Many children with cerebral palsy have sleep apnea, and it can be very easy to miss. And maybe finally, another one that is very important is neuromuscular diseases, okay? Again, Again, reflecting where you start seeing changes in the quality of their sleep that may manifest to their daytime functioning. So, but I could spend really all this hour talking about each one of these conditions and how they may manifest and what the potential implications are. But suffice it to show you that this is a very frequent and many conditions that we don't think too much about, such as sickle cell disease, are associated with a very large prevalence, or asthma. A very nice comorbidity of sleep asthma is sleep apnea, and sleep apnea can lead to exacerbate asthmatic symptoms. So what are the pertinent clinical findings? Not a lot, really. During sleep, we will have habitual snoring, difficulty breathing during sleep with snorting episodes, restless sleep, a lot of awakenings, excessive sweating during the night, night terrors, bedwetting, and parents will witness what they call the stopped breathing. It's not really stopped breathing. They don't hear the sound because the child is obstructed, no airflow. So of course they think that he stopped breathing. There's actually breathing very hard against an occluded airway. During the daytime, mouth breathing, limited nasal airflow, nasal discharge, these adenoid facies, recurrent ear infections, very frequent in children with sleep apnea history, will reveal that they may have had at some point in time or continue to have recurrent ear infections. Difficult sometimes swallowing, particularly if the tonsils are very large, pectus excavatum, retrognathia, and large neck circumference for those that are obese, with truncal obesity. And one important thing, if you see a child that keeps coming to the primary care for respiratory symptoms, start suspecting and ask at least the question, does the child snore? Because that will give it away. We have found in multiple epidemiological studies that these kids at least triple the number of visits to the primary care physician than anybody else, and it's usually for respiratory issues. So what do you find severity? Well, you can see that adults, the conditions are different. An AHI represents an obstructive apnea and hypopnea, hypopnea being this partial collapse of the airway that leads to either desaturation or arousal. And apnea, of course, it's a complete cessation of the airflow. And you can see that for children, normal would be 0. Less than 1 is considered absolutely normal. It's 2 standard deviations beyond the mean of 0, 0.1. And so depending on the labs, we consider either 1 or 2 for these events. And certainly anything below 5 will be considered between 2 and 5 or 1 and 5, depending on the lab, will be considered very mild sleep apnea. You can see that adults, 5 is already normal. So this illustrates the fact that adults have a much larger, much more collapsible airway compared to kids. Moderate between 5 and 10, and more than 10 is considered severe, where adults more than 30 would be considered severe. So it is important because when children go to a laboratory that is not particularly proficient with children, there might be substantial misdiagnosis, and children between 5, 6, or 7 may be called no big deal, when in fact they already have disease that is significant and should be treated. So again, I just want to illustrate the importance of applying children's or pediatric criteria. One of the problems of everything that we do in the polysomnogram at this point, however, is that we count sheep. Now, I tend to fall asleep when I count sheep. I don't know about you. But the important thing is we have a fantastic record of many, many physiological measures that we score with great effort, counting every event, defining every event, and then we assemble them as an obstructive apnea-hypopnea index, oxygen desaturation index, how many events per hour sleep happen of 3% desats, 4% desats, how many arousals per hour of sleep happen. But that's what we do. And we then throw away that study. And yet there's electrocardiogram and saturation and EEG of multiple channels and the respiratory muscle activity. And we don't do much about it. And so I will try to show you at the end of this talk that we need to do better if we want to data mine the huge amount of information that is contained within the sleep study, and that how important that could be in order to perpetuate the need for sleep studies, because otherwise just measuring oximetry and counting sheep or doing something else with with machine learning, we can probably achieve the same results, and or at least the majority of the kids can be diagnosed that way. So we need to understand what else can we get in order to define a phenotype and going into a little bit more of precision medicine in the field of pediatric sleep apnea. So for those who are general pediatricians or want to be general pediatricians, what would be my recommendation? This is what I call my Snore Plus advice. Child snores, there's habitual snoring. What else should prompt you to at least consider sending a child like this and referring the child for more evaluation? If the child reports or is viewed as being sleepy during the day, if the loud snoring is clearly present to the point that it worries parents, stop breathing during sleep, morning headaches, behavioral issues, bedwetting, parasomnias, a lot of night terrors, nightmares, bruxism should prompt you that something is also wrong, trying to modify the position of the mouth by doing masticatory activity that is a way of maintaining the upper airway tone. Mood swings, asthma, if there is a coexistence of asthma, don't drop it, just send them for referral because, as I said, one can exacerbate the other. Recurrent otitis media and mouth breathing. So it is a simple list, and yet it is a very important list in order to understand when a child, at least for sure, deserves to be referred. Now, why are we concerned about sleep apnea? If snoring and sleep apnea did not cause any morbidity, it would be just a symptom. It wouldn't be a disease. So there are consequences, morbid consequences, and this is a long list of many of them, all of them very important. Neurobehavioral deficits, attention deficit, hyperactivity-like behaviors, depression and low self-esteem, excessive daytime sleepiness, systemic hypertension, left ventricular hypertrophy and remodeling, pulmonary hypertension and cor pulmonale, failure to thrive for a subset, clear reduction in the quality of life of many of the kids to levels very similar to those of children with leukemia receiving therapy. So not a trivial reduction, or many other chronic diseases associated with pain or with complex treatments. And of course, bedwetting as well. So many years ago, Dr. Ronnie Ahrens, who was a fellow with me in Los Angeles and then moved to CHOP and ultimately to Einstein, did a very seminal study where he tried to quantify the size of the tonsils and adenoids in children with and without sleep apnea using MRI. And the important thing that he found was that there were several things. One is that the airway was small. These were children mildly sedated in the magnet. And so the airway was small, and the size of the tonsils and adenoids was also, of course, enlarged as you would expect it. And the more important thing was that it is in the section where there's overlap between the adenoids and the tonsils that in otherwise normal children, healthy children, this is where the overlap of those two tissues is where the collapse tends to happen. So it's an important element. It's very different from the premature infants, where the collapse tends to happen superior to this side. So again, showing you that different levels of collapse may have different need for different treatments. Again, an area that with the advent of DICE and the ability to do drug-induced endoscopies, we can now sort out exactly where the collapse happens and to guide a little bit the decision to treatment on the basis of the findings. Elements that we do, of course, we're not going to do MRI to everybody, but we can at least quantify and speak the same language when we communicate on the size of tonsils. These are the Brodsky criteria. They're used by every otolaryngologist or every one of us. And we defined the presence of zero tonsils means that they're gone. Level 1, you don't see them really. Number 2, 3, and 4, depending on their size, it's easy to see on the picture. But it's important to define these when you do your physical. But one thing that we usually don't do, and we should, is quantifying lingual tonsil. And lingual tonsil is important because if there is a very large lingual tonsil, which by the way happens more readily in children with obesity, it may be one of the determinants of failure of your adenotonsillectomy. So having a quantification of the adenoid tissue within the lingual base of the tongue is also an important feature. And I'm just showing you some pictures to illustrate their importance. Now, it needs to become clear. This is work by Carol Marcus. Unfortunately, she passed away suddenly due to an intracerebral hemorrhage. She was a fantastic sister of mine, professional sister. We went along all of our careers in parallel, and she was a fantastic clinician researcher. And she published this paper back in 1998 to illustrate that children with sleep apnea have highly collapsible airways. And the moment that the collapse, and so what she did, she applied almost like an aspirator, a negative vacuum during sleep to show that airways in normal kids are very, very resistant to collapse. But as the pressure reached a certain pressure, what we call the critical pressure to collapse the airway in the normal child will be -30, -25, -20. As the pressure became more positive towards more positivity, which means that you needed less pressure, negative pressure to collapse the airway during sleep, that indicated that the airway was collapsible. And you can see that the apnea index started going up as the negative pressure that was needed to collapse the airway was less negative, okay? So this is really the first work showing that the airway of children with sleep apnea is highly collapsible. And by doing a little trick and applying topical anesthesia to the airway and looking through with an echo Doppler at the airway, we could do this during wakefulness in children in the clinic and show exactly the same findings, to the point that a certain level of decline in the oversized cross-sectional area of the airway was allowed us to do predictions of the severity of sleep apnea in the clinic. So this is essentially replicating the very interesting findings that Carol found. So one wonders, okay, so what are, from all the diseases that I showed you that are associated with sleep apnea, what is going on? Some kids will have kissing tonsils and yet don't have sleep apnea, and others have barely any tonsils, and yet they have very significant sleep apnea. So something must be going on. And this is really the interface of all the elements that really play a role in sleep apnea, both the airway occupying elements such as obesity and deposits of fat in the airway or tonsils or adenoids, but at the same time, craniofacial features, if you have retrognathia, maxillary or mandibular growth deficits, or having neuromuscular reflexes, airway controls through the process of muscular responses or control of breathing. So all of these play a role, and you can see that different kids will be situated in different parts of this Venn diagram in order to, as part of their pathophysiology for sleep apnea, which therefore just treating the airway occupying lesion may not necessarily resolve the problem in a large cluster of kids. Now, I'm going to focus a little bit on obesity because it is, I'm sure here, the same way that in every clinic that I have done in pediatric sleep, we've seen an escalation of the number of obese children that come to my clinic and to our sleep clinics. Today in West Virginia, and we have about 80% of the kids that come to us are obese, which is terrible. We all know. But one can wonder what happens in children, and the prevalence of sleep apnea goes up from 44% to 40% in obese children. Okay, so it's not a joke. And yet, the majority of obese children that come to supposedly are healthy and come for well child visits do not get referred. And that's one point that I want to really emphasize. You see an obese child, ask at least about sleep symptoms, ask about all the things that the Snore Plus questionnaire, and if there is anything in there, please think that the probability that you will identify a child with sleep apnea will go up tremendously. And Dr. Redline, Susan Redline, now at Harvard, showed that in adolescents, for any BMI increase of 1 kilogram per meter square, the risk increased 12%. So it's obviously a dose-dependent effect. So we did a study in Spain. I was one of the founders of the pediatric Spanish sleep group, as well as the adult one. We did a cross-sectional well child visits of obese children coming to primary pediatricians. We studied 248 kids, about 55% were males. They were between the ages of 3 to 14. We did a very long list of measurements, but the important thing is shown here. And what we showed, depending, it doesn't matter which of the criteria we use, whether there was an obstructive apnea, hypopnea, Monder 1, for those of you who like the 1, if you use 3, if you use a respiratory disturbance index as opposed to the prevalence in a general population that was otherwise considered to be healthy, except for the presence of obesity, was about 40%. Okay, and this is in Spain, where the prevalence of morbid obesity, the way we see it here, does not exist, virtually does not exist. So I just want to point out how important it is to be sensitive to the presence of obesity in a child and make sure that we ask about their sleep, because disruptions of their sleep will translate into perpetuation of their obesity. Poor quality sleep leads to dysregulated orexin systems, satiety, the ability to engage in physical activity by virtue of being tired, which then ultimately leads to this vicious cycle of perpetuation of the obesity, leading to then the consequences of obesity and of sleep disorders. Now, children with obesity also have increased size of their lymphoid tissues in the airway. This is work by Ronnie Ahrens again, repeated the same studies, this time in children with obesity, and showed that indeed the tissues, both in the airway as well as in the abdominal cavity, the deposits of fat, were actually markedly enhanced at the same time that lymphoid tissues were also enhanced. And so this is sleep apnea too, by the way. What you're seeing here is sleep apnea in a child. What we did here was to take monocytes of children with sleep apnea compared to controls and perform a bulk RNA transcriptomic analysis. This is work back from 2009. And if you see, and we did a network analysis, and what you see is that the major element that was concentrated as part of the fundamental core or station of the network, that could be the most important one shown here, was that this illustrated in the inflammatory response. So if you want to remember something out of the sleep apnea, is that it is a low-grade systemic chronic inflammatory disease. This is what sleep apnea is. Low-grade systemic inflammatory disease. Okay? And that really then percolates to all the consequences, or virtually all of the consequences that we see. Okay? So now, if you want to do it a little bit more modern, this is now single-cell transcriptomic analysis of the same children, not the same exactly, but children with sleep apnea compared to controls. This is work by René Cortese in our group. And you can see that now we can identify unique populations of not only of every one of the cells has a different transcriptomic phenotype, but also we identify unique inflammatory cells that were not known before and are actually typical of sleep apnea. So there is an immune response that is very, very specific to the disruption of sleep, the presence of all these gas exchange abnormalities that is translated into our immune cell profiles. And if we apply computational dynamics, which were now verified in almost 1,000 children, we identify 32 genes in those cells, even in bulk RNA. It continues to be valid, that allow for 96% prediction, accurate prediction of sleep apnea. So in other words, if you just want to know as sleep apnea, no sleep apnea, and no want to do a sleep study, that would be sufficient. And so this is important, because what is important too is that the pathways that are involved are different in each child. And so understanding the transcriptomic pathway of these cells and what they're doing may lead to very different approaches to the treatment of these children in the near future. And that's where we're pursuing very aggressively now. Now, you may think, okay, well, is there a lot of inflammation in the airway? Yes, there is. This is a study that was done by Jyoti Krishna and Aviv Goldbart when we were in Louisville. We devised a little system, just collect condensate of the upper airway. And indeed, what we found is that there was increased cell proliferation of the tissues, of the lymphoid tissues, but they also released more TNF and interleukin-6 and 1. Here shown the interleukin-1, and that these were particularly related to CD8 positive cell lymphocytes. Clustering of CD8 positive cell lymphocytes in the lymphoid tissue releasing very large increases of both pro-inflammatory cytokines. So you can see that there's a soup within the tissue that is different from other children, such as those with, for example, recurrent tonsillitis, but without sleep apnea. And that is important because it's telling us that there is a different immune response. And as I showed you now, even in the circulation, we can pick this up. Of course, there are differences between different children. So in a way, we proposed that there would be at least two phenotypes. This was the first attempt at defining phenotypes in children with sleep apnea. Since then, that we added the third one, which is the congenital kids with a variety of craniofacial malformations. But I'm showing just two to show you. The kid type 1, similar to diabetes, type 1, children that are non-obese, and type 2, children with obesity, very similar to the adults. You can see that sleepiness is particularly manifest in the obese children, not as much in the non-obese children, which instead will manifest attention deficit-like behaviors. And you can see that all the rest, there are certainly differences in between the two that maybe help us kind of define a little bit how to go ahead and proceed with the management of these children. Now, for many years, since Dr. Guilleminot reported the sleep apnea for the first time in six children, he already alluded to the fact that parents had communicated that these kids had problems with learning. They seemed to have problems with school, problems with learning. So back in the 1998, when I was at Tulane, we went to all the public schools of New Orleans. We asked the teachers to identify the first graders of every first grade class, to identify the two worst students in the classroom. Now, when mayor comes, they want to know who the best children, the brightest, the more successful ones. You should see the teachers. What do you want? Well, I would like to, can you tell me who are the worst two students in your class? Oh, it's easy. It's Johnny and Mary, mostly Johnny. Okay? I knew that would. So we collected 297 kids like this, did sleep studies, and what we found was that the prevalence of sleep apnea in this academically failing first graders was about ninefold that would be predicted for the general prevalence of children with sleep apnea in the population. But that was not the important things. Once we knew the results, we felt we were compelled to tell the parents what they found. And so we had four groups, a group of children that had no sleep apnea, a group of kids that had snoring, did not fulfill the criteria for sleep apnea, and then a group of kids with sleep apnea. We told the parents and recommended that they would go to an ENT and get adenotonsillectomy, the standard of therapy. Some said, wonderful, doctor, we're going to do exactly what you tell us, and they did. And others said, we're very proud, it snores as loud as Papa, so we're going to keep doing and not do anything. We found out what they did, but we didn't tell the teachers. And the year after, we asked them to tell us the grades of those kids. And what you see in black is the kids that were treated. This is the only group that was treated. Their grades improved so much that except for 2 of the 26 that were treated, they all came out of the bottom of their class. I have 24 letters from the parents telling them how this was radically life-saving for their kids. And I keep them very preciously because this, for the first time, showed 2 things. One, it showed that kids with academic failure are more likely to have sleep apnea, but more importantly is that it is reversible. Okay? We don't know if completely reversible because we don't know what the original potential of these kids was, but at least that it is at least partially reversible. So this was really important for us. Now, in that, and with other studies that were being published at the same time, there was the famous child adenotonsillectomy study. The problem is that we needed to be very careful with the selection of the kids that we would engage, because it involved bringing kids with sleep apnea and either randomize them to either adenotonsillectomy or really nothing, and then wait for 6 months after adenotonsillectomy and repeat all the studies again, including cognitive function. And so kids with very severe disease were excluded, kids with a lot of symptoms were excluded. So you can see that we reduced it to a very relatively mild sleep apnea contingent, right? We felt that there was only equipoise as far as our ethical decision. And so when they were treated, we found that it improved quality of life, but we did not see improvement in cognition. And we were all very disappointed. In retrospect, we should have expected it. Because if you're born with an IQ like all your kids, if you have kids, or all of you, you were born with an IQ of 200, and you lose 8 IQ points, nobody would notice. Okay? But if you're born with an IQ of 100 and lose 8 points, it's the difference between going to college or not. And so most of the cognitive tests are done with the intent of identifying kids with developmental delay, not in identifying kids with subtle changes in their cognitive abilities, where the variability from day to day is much wider. The higher you go, the more variability you have to day based on a variety of factors. So we shouldn't have expected, but if we took those kids that had lower cognitive function and looked at the effects, what we saw now, there were 7 of those in a total of 400. As you can see here from the paper, there was an improvement, suggesting that we recapitulated again the same findings, that there's a group of children that are more vulnerable, and those that are vulnerable to the disease, even at mild level, are going to be most likely the ones that show us the benefit when we start treating them, okay? So we wanted to know if there is a dose dependency. So this is a study that we conducted in Chicago. 1,100 kids were screened from the general population with clustering towards snoring. Of course, we wanted to have more snoring in that population. We did really sleep studies, cognition, very, very complex measurements, and divided them into 3 or 4 groups. Non-snoring kids, control kids, kids with primary snoring, in other words, nothing else, then kids with mild or moderate to severe sleep apnea. And for every measure of cognition, we saw that in this large cohort, now that you have the power of numbers, as the severity of sleep apnea increased, in any of the cognitive functions, we saw a progressive decline, but of course, with a large degree of variability, as you would expect. And so this further confirms, one, that the tests are probably not very reliable for you, but that there is an underlying vulnerability that is going to be manifest, at least in a subgroup of kids, at any level of disease, okay? And this is why we conducted then a study that was almost paradoxical. We took kids with moderate to severe sleep apnea that did not have cognitive deficits, but run them now to the magnet to take a look whether they had gray matter loss. And you can see there in the areas shaded here, compared to a very large group of controls, you can see that the shaded areas in yellow indicate the areas where there were statistical declines in gray matter in children with severe sleep apnea, moderate to severe sleep apnea, but no cognitive dysfunction. In other words, even though if we don't see it, the damage is already there, okay? And that is important. Okay, that is an important facet. So we may not have currently, at least on the basis of our neuropsychological testing, we may not have the appropriate tools to actually identify who's really at risk. And that is an important finding. The other point that I wanted to make is that for kids, just the presence of snoring, this is a study that we did on another cohort of about 1,000 kids, snoring, but without sleep apnea, where you can see that the frequency of snoring is associated with an increase in the behavior, not in the cognition, in the behavior. So inattention and inability to concentrate on any tasks is the one that seems to be primarily affected in with behavioral hyperactivity and inattention. So snoring appears to be a very important component, particularly as it relates to poor quality sleep, leading to this underlying sleepiness that manifests as inattention and difficulty with concentration. So this is what I was telling you before. If you have an IQ of 120 and you lose something, it's very difficult unless the loss is really significant. You're not going to be able to pick it up. But it's only in the more vulnerable kids that you're going to see this in the neuropsych tests. So something else needs to be identified to be able to predict who is at risk. The other element that children are at risk for, and yet we don't measure it, is their vascular bed. We all think that, oh, it's perfect. And yet some kids will develop hypertension, mild hypertension, particularly diastolic hypertension, either during exercise or during the night. But if you measure vascular dynamics in looking at endothelial function, this is a simple test of what we call a reperfusion test. You occlude the arm or the circulation for a period of time. You release it in a standardized way. And what you should get is to have a relatively speed recovery going to peak perfusion very quickly, indicating that the endothelium is healthy and is able to release a lot of nitric oxide in order to fill out the deficit or the mild ischemia that took place. So you can see here on the top that we've done this in a normal child, a healthy child, and a kid with sleep apnea. And you can see that the peak reperfusion time, the time to peak reperfusion is delayed, indicating that there is endothelial dysfunction. No hypertension, no other symptoms. This is a silent morbidity that we are completely oblivious to. Now imagine that you have this for a long period of time. It may lead ultimately to atherosclerosis and to cardiovascular morbidity, not now, not with their kids. At age 20, 35, 40, that's their first MI. How come that they had the first MI? Did you have snoring and did you have sleep apnea that was not treated then? Oh yeah, I used to snore. Okay, so that's what I want to put. The consequences may only be manifest many years later. When you ask me what the prevalence is of this endothelial dysfunction, they show here two groups, obese and non-obese for obvious reason. With mild OSA, the prevalence is about 15% in otherwise non-obese children and 40% in obese children. And in kids who are with mild to moderate to severe sleep apnea, 20% in non-obese kids and 60% of the obese kids. So the question is, how come that there are 37.5% of the obese kids that don't have it? And this is an important element, the issues of vulnerability and what determines vulnerability, okay? So this is what we have come up with. This is a long, many decades of work from our lab and others, showing you how the environment, the severity of sleep apnea, and the individual susceptibility all play together. If you eat good food, if you exercise, if you live in a non-polluted environment, if you don't live under high stress, if you are a very enriched environment intellectually, that is going to protect you. Exercise is going to protect you. Junk food is not going to protect you. Okay, we have the studies done in animals to confirm everything else. Of course, the more severe the disease I showed you, the more likely that you're going to have it. And then there are genes that predispose you. So if you were born with a gene that predisposes to Alzheimer's as a kid, and you have sleep apnea, you're more likely to actually manifest cognitive deficits than one who doesn't. And there are a long list of a variety of mechanisms, oxidative stress, inflammation, and so on, that whose variants, single nucleotide polymorphisms or variants, may manifest as individual susceptibility changes. And I should also mention that if you're born premature, of course, you also have that, depending on your age and depending whether you're obese or not. So what about phenotypes? Can we detect clinically relevant phenotypes? And that is an important feature that I wanted to illustrate to you. I told you before that I would show you whether the EEG can contain information, for example. This is work by, excuse me, Dr. Gutierrez Tobal in University of Valladolid. This is a group that does machine learning and artificial intelligence, explainable AI. We collaborate now for the last 12 years or so, and what he has been able to show is that the dynamics of the EEG throughout the night using AI-based explainable AI allows us to identify kids that have cognitive deficits from the EEG of the sleep study. So we don't need to do neurocognitive testing and all this other stuff. All we run it through, identify the algorithm will seek whether the kid has. And there is what we call a mass effect towards condensations. You're using all the resources of the brain during sleep. Because of your disturbed sleep, you're using all of these resources just to keep the integrity of the system. That is telling you that you're overloaded. And if you're overloaded, you have cognitive deficits, okay? This is called gravitational explainable AI, and this is a very sophisticated mathematical component, but one that delights me every time because I'm a major in math and I still have difficulty looking at all the differential equations that these guys are able to do. The other thing is that by taking a lot of the clinical-based phenotypes along with all the other elements, whether it's heart rate variability, EEG, and so on, you can actually define the susceptibility of any given child at the individual level for cognitive deficits. And that is important. Or you can predict whether this adenotonsillectomy is going to be successful. So a priori, just by virtue of your sleep study and your clinical phenotype that you're obtaining in your HNP and physical exam, you can actually predict who is going to be successfully treated and who not, and who is going to need a repeat sleep study or need something else to be done, okay? So just to show you the power of what we have today, and I'm sure that you understand why this is important at the time that we all our parents and us, seek as much as predictive analytics as we can. So this is what we're going now. That we were just funded to do an explainable AI to take huge databases that are available, including ours, start condensating about 10,000 or 12,000 of sleep studies with all the clinical information and start squeezing the hell out of it with all these mathematical operators in order to identify something that is applicable around the world, not just in the US or not just in so on, in order to make sure that we can, in the very near future, we can provide you with a simple algorithm that will reside in the cloud, take your sleep study, load it there, and you get within a few seconds, you will get, this is your risk phenotype, this is your cluster, this is what you need to do. This is where we would like to go. So these are the future directions. I think that they're going to be biometric sensors that link to AI and deep learning algorithms, plus or minus urine or blood tests. I showed you some of the genes, the transcriptomic genes that may be of relevance to both the sleep apnea or not, or potentially morbidity, such that we can identify children with increased susceptibility. And this should allow us for improved precision, personalized approaches to the treatment of these children. So these are the people that I talked about. They, of course, deserve all the credit for everything that I am the pleasure of presenting to you today. And I'm more than happy to answer any questions. Thank you.